is the first video for endocrinology. The first topic is pituitary gland. Dynamic pituitary function test is used to assess patients with suspected primary pituitary dysfunction. Insulin, thyroid releasing hormone, luteinizing hormone, releasing hormone are given to the patient. Following that, the serum glucose, cortisol growth hormone, TSH, LH, and FSH are recorded at regular intervals. Prolactin levels are also sometimes measured. GH levels more than 20, cortisol level rises more than 550, TSH more than 2 from baseline, and LH is double. Assess the function of pituitary gland. Dopamine antagonist tests using metoclopramide may also be used in the investigation of hyperprolactinemia. A normal response is at least 2-fold rise in prolactin. A blunted response suggests a prolactinoma. Pituitary tumors. Hormone secreted by a pituitary tumor. PRL, prolactin is 35%. No obvious hormone, non-functioning growth hormone 20%, PRL and GH 7%, acetate 7%, others 1%. So prolactin is the one which is to look out for. Growth hormone. It's secreted by somatotrophs of the anterior lobe of the pituitary gland. It has actions on multiple organ systems and is important in postnatal growth and development. Growth hormone is also responsible for changes in protein, lipid, and carbohydrate metabolism. Growth hormone stimulates the liver and other tissues to produce somatomedins which promote growth. Growth hormone is also anabolic hormone and diabetogenic, exerting an anti-insulin effect in muscle and increasing hepatic glucose release. So it's opposite to what insulin does. Acromegaly occurs when growth hormone hypersecretion occurs after puberty, and the growth plates have fused so that only flat bones enlargement and soft tissue growth is possible. By comparison, gigantism occurs if growth hormone hypersecretion occurs before epiphyseal fusion. So this one is before epiphyseal fusion, acromegaly is after epiphyseal fusion. Okay, mechanism of action. Growth hormone acts on a transmembrane receptor for growth. Binding of growth hormone to the receptor leads to receptor dimerization. Acts directly on tissue and also indirectly via insulin-like growth factor, primarily secreted by the liver. And condition is associated with growth hormone, excess growth hormone, acromegaly, and growth hormone deficiency resulting in short stature. For acromegaly, there is excess growth hormone secondary to pituitary adenoma, and usually 7%. In over 95% of cases, a minority of cases are caused by ectopic growth hormone or released by tumors like pancreatic. 95% of cases are due to growth hormone secreting pituitary adenoma, and less than 3% of cases are due to ectopic growth hormone releasing hormone production, like a carcinoid tumor, especially bronchial, pancreatic, islet tumors, or adrenal tumors. The condition may arise as part of the type 1 multiple endocrine neoplasia syndrome. 6% of patients have MEN1. We'll come back to that later. The features of acromegaly can be coarse, oily skin, large tongue, prognathism, interdental spaces, spade-like hands, increase in shoe size, sweating due to sweat gland hypertrophy, features of pituitary tumor, hypopituitarism, headaches, and headache, and bitemporal hemianopia. Raised prolactin in 1/3 of the cases can lead to galacturia. So these are the features we need to look out for. Large tongue, spade-like hands, increase in shoe size, excessive sweating, and then features of pituitary tumor, headache, bitemporal hemianopia, hypopituitarism. Acromegaly is associated with systemic, not pulmonary hypertension. Complications can be hypertension, diabetes more than 10%, cardiomyopathy, and colorectal cancer. The diagnosis for acromegaly: growth hormone levels vary during the day and are therefore not diagnostic. The definitive test is the oral glucose tolerance test, OGTT. Failure of growth hormone to be suppressed by 75 gram oral glucose. False positive test occurs in poorly controlled DM, anorexia nervosa, hypothyroidism, Cushing's. May also demonstrate impaired glucose tolerance, which is associated with acromegaly. So with OGTT, there is failure of growth hormone to suppress by oral glucose. Insulin-like growth factor 1 levels, better So here basically 2 hours OGT test, you give sugar and check how growth hormone responds. So growth hormone doesn't suppress, which can show evidence for acromegaly. Insulin-like growth factor 1 better test than growth hormone levels because IGF levels are less variable. Increase in pregnancy and puberty may also be used as a screening test and is sometimes used to monitor disease. MRI CT scan may reveal pituitary adenoma. Chest and abdominal radiology may detect an ectopic source of growth hormone. May detect cardiomegaly due to cardiomyopathy. Hands radiology reveals tufting of terminal phalanges, increased joint space due to cartilage hypertrophy, and assessment of pituitary function. Hypercalciuria is common in acromegaly due to direct renal tubular action of growth hormone. If there is moderate or severe hypercalcemia, then this is suggestive of hyperparathyroidism, MEN1, hypercalciuria, and increased phosphate. Management for acromegaly is transsphenoidal surgery. That is the first line treatment for acromegaly in most patients. If causes of acromegaly is the macroadenoma, then transsphenoidal surgery exploration. If there is symptomatic improvement, insulin-like growth factor is normal, then growth hormone concentration less than 5, then no further treatment is indicated. If the above conditions are not satisfied, then external invitation. If there is a macroadenoma more than 1 centimeter diameter, then surgery is the choice. And patients can benefit from external beam radiotherapy, and drug treatment may also be indicated in order to get growth hormone levels below 5. If patient is elderly and surgery is contraindicated, octreotide can also be used. That is somatostatin analog. It's effective in 50 to 70% of patients. May be used as an adjunct as it helps to control cardiometabolic risk factors prior to surgery. Pegvisomant, growth hormone receptor antagonist, prevents demineralization of the growth hormone receptor. Once daily subcutaneous administration. Very effective, decreases IGF levels into 90% of patients to normal, doesn't decrease tumor volume, therefore surgery is still needed if mass effect. Dopamine agonist can also help. Generally not very effective except in mammosomatotrough tumors that secrete growth hormone prolactin. Dopamine agonists stimulate growth hormone release in normal individuals, but paradoxically in patients with acromegaly suppress growth hormone secretion. Bromocriptine suppresses growth hormone, serum growth hormone below the suboptimal level of 10 mU per liter and normalizes IGF levels. Newer dopamine agonists like cabergoline and quinolide normalize serum IGF levels in approximately 40% and are better tolerated. Dopamine agonists are more effective where there is co-secretion of prolactin. External irradiation is sometimes used for older patients for following failed surgical medical treatment. Okay, prolactin. Prolactin is secreted by the anterior pituitary gland, with release being controlled by a wide variety of physiological factors. Dopamine acts as the primary prolactin releasing inhibitor. So dopamine inhibits prolactin. Okay, and hence dopamine agonists such as bromocriptine may be used to control galactorrhea. It's important to differentiate the cause of galactorrhea due to the actions of prolactin on breast tissue from those of gynecomastia. Prolactinoma is the most common form of pituitary tumor, as we've said before, accounting for approximately 50% of pituitary adenomas. So prolactin is unique amongst the pituitary hormones in being tonically continuous inhibited by the hypothalamus. So it's inhibited by the hypothalamus all the time, continuously. So what are the features of excess prolactin? Men would be impotence, loss of libido, and galactorrhea, that is milky nipple discharge. For women, it's amenorrhea and galactorrhea, milky nipple discharge as well. Causes of increased prolactin. Number 1 is prolactinoma, this is pituitary adenoma, micro or macroprolactinoma. Non-secreting pituitary adenoma may also cause hyperprolactinoma. This may occur if a non-secretory adenoma disrupts the flow of hypothalamic dopamine, the physiological prolactin inhibitory factor, to the lactotrophs. Pregnancy can cause increased prolactin. Estrogens can cause increased prolactin. Physiological like stress, exercise, sleep can cause excessive prolactin. Acromegaly, 1/3 of the patients. Polycystic ovarian syndrome. Primary hypothyroidism due to thyrotrophin releasing hormone stimulating prolactin release may occur as part of the MEN1 syndrome. We'll come to that later. And drugs like domperidone, metoclopramide, phenothiazine, haloperidol, very rare SSRI opioid. Note that spironolactone can cause gynecomastia, not increase prolactin. Okay. Now, for management of prolactinoma, medical therapy is almost always the first line. Prolactinomas are unusual as medical therapy is first line, even if visual field defects are present. The main indication for surgery are tumor resistant to dopamine agonist. So the treatment is dopamine agonist, as we've said. Dopamine inhibits prolactin. So bromocriptine and cabergoline. Treatment generally needs to be continued until the menopause. Endocrinological advice should be sought if the patient wishes to become pregnant while undertaking treatment with a dopamine agonist. Gynecomastia. It describes an abnormal amount of breast tissue in the males and is usually caused by increased estrogen to androgen ratio. It's important to differentiate the cause of galactorrhea due to the action of prolactin or breast tissue from those of gynecomastia. Cause of gynecomastia can be physiological, normal in puberty, syndromes with androgen deficiency like Kallman's and Klinefelter, testicular failure like in moms, testicular cancer like seminoma secreting HCG, liver disease, ectopic tumor secretion, hyperthyroidism, not hypothyroidism, then hemodialysis, to know about that. Okay, commonly causes gynecomastia are spironolactone, cimetidine, digoxin, cannabis, finasteride, estrogen, anabolic steroids. Rarely cause gynecomastia, tricyclic, TCA, isoniazid, calcium channel blocker, heroin, busulfan, methyl-dopa. Okay, next topic is SIAD. Symptoms of inappropriate ADH secretion. Okay, the criteria is normal renal, normal adrenal, and normal thyroid, and no diuretics. That's when you start thinking about SIAD, and having hyponatremia and hypotonic plasma. Of course, inappropriately increased osmolality of urine, and urine sodium more than 20. So that's going to be SIAD. So causes can be malignancy, especially small cell lung cancer, and also pancreas, prostate cancer. Infections can also be cause of SIAD, TB, pneumonia, stroke. Neurological causes are very commonly seen in neurological patients: stroke, subarachnoid hemorrhage, subdural hemorrhage, meningitis, encephalitis, abscess. Drugs that can cause SIAD: sulfonylureas, SSRI, tricyclics, carbamazepine, vincristine, cyclophosphamide. Other causes can be PEP, porphyrias. Needs to be studied again. Okay, so what are the causes of SIAD again? Infective, primary brain injury, drugs, malignancy, decreased serum osmolality, increased serum volume, and kidneys. So this like ADH secretion is there. So vasopressin binds to receptor in the kidneys, allowing increased water reabsorption from urine. So a lot of water is held back, so causing sodium to be low. Increased urine osmolality, increased urine osmolality, and decreased urine volume. Okay, other points to diagnose: maintain hypervolemia, suppression of RAS, no equal concentration of A and B, decreased BUN, normal serum creatinine, uric acid, decreased albumin, decreased normal acid base balance, potassium balance. Treatment for diagnosing hyponatremia, refer to basic science chapter. Oh, okay. Hyponatremia we've already done in clinical science. So acute hyponatremia with hypotonic 3% saline, IV furosemide to correct fluid overload if needed, and chronic is like fluid restriction, SIAD, and temeclocycline can also be given. It can cause reversible azotemia and sometimes nephrotoxicity, especially in patients with cirrhosis. Not really given. Okay. Androgen insensitivity syndrome. Okay, the next is androgen insensitivity syndrome. Is an X-linked recessive condition due to end organ resistance to testosterone, causing genotypically male children 46XY to have a female phenotype. So resistance to testosterone, that's the main line to remember. Okay, complete androgen insensitivity syndrome is a new term for testicular feminization syndrome. So diagnosis is buccal smear or chromosomal analysis to reveal 46XY genotype. The features will be primary amenorrhea, undescendant testis causing groin swelling, mm, groin swellings. Breast development may occur as a result of conversion of testosterone to estradiol, and counseling child raised as female. Bilateral orchidectomy increases of testicular cancer due to undescendant estrogen therapy. So you raise the child as a female. Okay. Questions will be in the adrenal section. It's coming up next later. Next is thyroid and parathyroid glands. Then we'll have all the thyroid disease followed by parathyroid and then diabetes for a long time. Diabetes will be a long chapter. A lot of things included in diabetes. And next there will be adrenal and everything, metabolic syndrome and everything all together. So it's a good chapter. It's a big chapter. Thyroid and parathyroid gland, what will it include? First is thyrotoxicosis, and the cause of thyrotoxicosis can be Graves' disease, toxic nodular goiter, subacute thyroiditis, that is Duquervin's thyroiditis, postpartum thyroiditis, acute phase of Hashimoto's thyroiditis, toxic adenoma, amiodarone therapy. Investigation is decreased TSH and increased T4T3. Graves' disease is confirmed in secondary care by testing for TSH receptor antibody. That is TSH RAB, commonly shortened to TRAB, and which have a 98% sensitivity and 99% specificity for this condition. So the receptor antibody is the one. The measurement of TRAB can distinguish between Graves' disease and other cause of hyperthyroidism, such as toxic adenoma and toxic multinodular goiter. So if TRAB is negative, a scan of radionuclide thyroid uptake with radioiodine or technetium can help distinguish different causes of hyperthyroidism. This typically shows diffuse pattern of uptake in Graves' disease. So diffuse pattern in Graves' disease. So first you do TSH receptor antibody. If it's negative, that's when you do radionuclide thyroid uptake. So if it's Graves' disease, it will show diffuse pattern, and one or more hot needles in toxic nodular hyperthyroidism. All types of hyperthyroiditis are associated with decreased or absent uptake of radioiodine isotope into the thyroid. So thyroiditis will show no uptake. Patchy uptake for toxic nodular hyperthyroidism, and TSH is used to assess the response of patients to carbimazole for treating Graves. So TSH is the marker, how you monitor the disease, assess the response of medicine. Thyrotoxicosis management, admit as a medical emergency. A person with symptoms of thyroid storm, if thyroid nodule or goiter and malignancy is suspected, refer urgently to endocrinologist. Thyroid function tests are usually normal in thyroid cancer. While awaiting specialist endocrinological assessment, consider beta blocker and titrating the dose depending on clinical response to provide relief of adrenergic symptoms, for example, tremor or tachycardia. So you give beta blocker. Consider starting carbimazole for people with distressing symptoms despite treatment with a beta blocker. Beta blocker is not tolerated or contraindicated. That's when you start thinking about giving carbimazole at first. Taking drugs is amiodarone, lithium, liaison between the specialist prescribing the drug and an endocrinologist may be needed. Now, next would be antithyroid drugs like carbimazole and propylthiouracil are used to decrease the thyroid hormone synthesis by acting as a preferred substrate for iodination by thyroid peroxidase. Okay, antithyroid drugs including carbimazole and propylthiouracil are used to decrease thyroid hormone synthesis by acting as a preferred substrate for iodination by thyroid peroxidase, the key enzyme in thyroid hormone synthesis. So it's acting as a preferred substrate for iodination. So it decreases thyroid hormone synthesis directly. Propylthiouracil is not used first line due to risk of severe liver injury, except in the first trimester of pregnancy and for treatment of thyroid storm. So in first trimester it's okay to use propylthiouracil. They should only be initiated on specialist advice and are typically used short term in preparation for radioiodine therapy, medium term with the aim of inducing remission of Graves' disease, and long term where radioiodine treatment or surgery is contraindicated. Most people with Graves' disease become euthyroid after 4 to 8 weeks of treatment with carbimazole. People with severe hyperthyroidism Large goiter or recent exposure to iodide may need a longer duration of treatment. After euthyroidism is achieved, two different regimens are used using carbimazole. First one is titration block regime, and the second one would be block and replace regime. Thianamide carbimazole 40 mg is used, and the dose adjusted every 4 to 6 weeks depending on the free FT4. T4. Okay, reduce the dose if FT4 level is decreased to low normal, or TSH is high, indicating the development of hypothyroidism. The aim is to allow endogenous thyroid synthesis of hormone to continue. Total typical duration of treatment is 12 to 18 months, and there is fewer side effects. Patients following titration regime have been shown to suffer fewer side effects than those in a block and replace regime. And for block and replace regime, this thianamide is used to block the synthesis of thyroid hormone. FT4 is monitored, and levothyroxine is added in when FT4 is in range. So, like, you give both carbimazole and levothyroxine and adjust. The levothyroxine doses are made to maintain normal FT4. For both regimes, the remission rate is 50% if treatment is continued for 6 to 18 months. Okay, radioiodine treatment. Radioiodine induces damage of DNA, leading to death of thyroid cells. So Graves' disease becomes euthyroid and then hypothyroid within 6 weeks to 6 months after completing radioiodine treatment. Large goiter may need high dose or repeated treatment to achieve euthyroidism. Patients may follow radioprotection measures. For example, close and prolonged contact with children and pregnant women should be avoided for 3 weeks after standard dose radioiodine treatment. Radioiodine is not recommended for the active Graves' orbitopathy, as it may cause prolonged progression of the condition. So, in case of eye problems and Graves' disease, radioiodine is not recommended. It's also contraindicated in pregnancy and breastfeeding women. Pregnancy should be avoided following treatment for at least 6 months for women, 4 months for men. There is no evidence of adverse effect on fertility, incidence of congenital malformation, or incidence of non-thyroid cancer in people treated with radioiodine of the children. The proportion of people who become hypothyroid depends on the dose given, but as a rule, the majority of patients will require thyroxine supplementation after 5 years. Hypothyroidism is the most common side effect of radioiodine, so it's important. And for surgical treatment, options include total or near total thyroidectomy, which may be indicated to prevent the recurrence of hyperthyroidism, in the management of compression symptoms from a large toxic multinodular goiter, in the management of coexisting potentially malignant thyroid nodule, if thianamide are not tolerated or ineffective, especially in pregnancy or active Graves' orbitopathy. Post-operative complications include hypothyroidism, hypocalcemia due to hyperparathyroidism as well, and vocal cord paresis due to damage in the recurrent laryngeal nerve. Thyroid storm is a rare but life-threatening complication of thyrotoxicosis. It is typically seen in patients with established thyrotoxicosis and is rarely seen as a presenting feature. Iatrogenic thyroxine excess does not usually result in thyroid storm. Features can be fever more than 38-degree temperature, 38.5, tachycardia, confusion, agitation, nausea, vomiting, heart failure, hypertension, abnormal LFT. Complication of thyrotoxicosis, it's typically seen with does not usually result in thyroid storm. So management can be symptomatic treatment like paracetamol, IV fluid, treatment of underlying cause, methimazole, propylthiouracil, local iodine can also be given. Dexamethasone 4 mg IV QDS blocks the compression of T4 to T3, propranolol.